205. You have it in your folders, and let me make sure we're working off the right substitute. That would be Representative Lindsay. Would that be LC295517 ERS? Okay, so that is the correct substitute, LC295517 ERS. And with that, I will turn it over to our whip, Representative Lindsay.
Thank you, Madam Chairman. A few years back, those of you who've been here for a while will remember my very good friend, now Mayor Tony Cumberland, who undertook the attempt to put together a comprehensive patient advance directive. Spent about a year, maybe 2 years, working on it with input from all sides. It took quite a beating, which is somewhat of a lesson in democracy. Representative Gardner and I saw his success and figured how hard could it really be.
Representative Lindsay, will you check your mic and see if it's on?
Anyway, after seeing Representative Tumlin's eventual success, Representative Gardner and I figured, how hard could it really be? Let's go ahead and just try to do one for psychiatric patients. And the answer is it's very hard. There are an enormous number of moving parts. I won't even try to joke this is a simple housekeeping bill, because that's not the case. But it does touch on extremely important issues for a large body of individuals in our state who are dealing with mental health issues and wishing to maintain control over their life, which is probably one of the most fundamental things anyone wants to try to do. We've worked with representatives from mental health advocates and also from physicians and other providers across the board. And we bring before you LC 295517 ERS in an attempt to move the ball forward with these very important advance directives. Representative Gardner, is there anything you want to mention before we get going on details?
I think it's obviously the devil is in the details, but I wanted to tell you that this has been a request from the Consumers Network, people who have experienced mental illness for many years. They have discovered that the answer to their treatment is in recovery, and a keystone of the recovery movement is personal responsibility for managing your care, and acknowledging that the mental illness, tends to be episodic. The suggestion is that they have had experience with, and in some other states, that they could come up with a directive, and this has nothing to do with end of life. We think about an advance directive as an end of life process, but this is a treatment plan. This is recommendations for how I'd like to be treated, because in the past, some of the people with mental illness have been put in mental institutions, and it's been a pretty devastating experience, and some of them have found themselves getting worse in those institutions. We're trying to keep them out of the institutions. We're trying to keep them out of jail. We're trying to get them into treatment early. No one disagrees with the importance of helping people with mental illness manage their illness before they get into a serious crisis and get into trouble, as they typically do. There are several states that have advance directives. There are places in our state where they have implemented advance directives. The importance of getting recognition by the hospital or wherever the person ends up, even in the doctor's office, we believe is really important. So the goal is to get the provider to take a look at this advance directive, be guided with the information. It's hard when somebody's in crisis to know what medication they've been taking, what problems they've been having. They will have a directive in their hand that will provide them with good information on how this person needs to be treated. That's why I think it's really important. I believe in early intervention, particularly in mental illness. We've seen some tragic situations recently in our country, And we believe it is time to at least take one step toward helping the people with mental illness learn to manage the crisis that they encounter early on. So the details have been worked on with the Hospital Association, the Medical Association, and the psychiatrists particularly, and the nursing homes for quite a long time, trying to create immunities so that they felt comfortable in negotiating. Sometimes the directive may not be exactly what the doctor thinks is the best treatment. We're trying to make sure that there are opportunities for this discussion to take place. I think I'll stop there. Obviously, the details of the bill are important, and I will leave that to my lawyer friend.
And one last comment to make. This kind of legislation, I believe, is some of the most important things that we work on. I can guarantee you that there are individuals in your district that this will help tremendously once we get the details down. I can almost guarantee you that it will help someone on your street where you live. And I dare say for many of us, it will, including myself, it will have a great benefit to loved ones. What this bill seeks to do is during those periods of time in which someone, what's the best way to put it, when someone is not in crisis, when someone is stabilized, for them to be able to sit down and sort of outline, the treatments that they've received before, the medications that have worked before, the medications that haven't worked before, and sort of outline the kind of treatment that they would like to consent to during times in which they are not in crisis. That's what the bill is designed to do. Sort of moving forward into some of the details of the bill, Section 1-2 are the various definitions that we use when it comes to the various individuals involved in the issue. 37-11-3 on page 3 outlines the contents of a patient advance directive, of those things that need to be provided in there. It also provides for the right to have a mental health agent to assist the treating providers to implement this particular PAD. It further sets out what's to happen if there is no agent, and that is for the directive to be followed. 37-11-4 outlines the various duties of an agent in terms of following the advance directive, and also setting out when the agent may deviate from the advance directive based on various conditions that may exist. 37-11-5 basically gives the agent the right to receive all the information that a patient could receive under HIPAA. 37-11-6 sort of outlines those individuals who, I'm on page 6 now, who may not act as an agent, particularly such declarance provider, such declarance provider or an employee of that provider, unless such employee is a family member. Basically, sort of keeping out conflicts of interest. 37-11-7 outlines the right to withdraw as an agent. 37-11-8 sets out the procedures for the signing of a physician advance directive. 37-11-9 lays out the ability to revocate a particular provision. A key part, I'm going to sort of jump around a little bit because I want to make sure we get to the key part. 37-11-11 on page 8 sets out when a provider may deviate from an advance directive, the circumstances in which that shall be permitted. The bill then goes, sort of jumping around to page 11. You will see beginning at page 11 through 24. You have basically what will be contained in an advance directive, the format that it needs to be contained on. And that's essentially the core of the bill, Madam Chairman. We have several people here who would like to testify as to it as well, but I'm more than happy to answer any questions.
I think I'd ask the committee to hold their questions, and since this has been an issue that's been on the table for a long time, I'd like for the advocates, if that's okay with you,
I
Representative
appreciate
Lindsay.
that. I think that's who y'all need to hear from.
Okay. The first person, if you'll come to the podium and state your name, Camden Pace.
Good afternoon, Honorable Madam Chair, esteemed members of the committee. My name is Camden Pace. I'm here to speak on House Bill 205. My request is that I respectfully ask that you pass this bill as written. I am a man in long-term recovery from a severe and persistent mental illness. I am hoping that today I will never have to worry about not having my honored lived experience put aside again. In 1998, I had found a medicine that worked very well for me. And through circumstances, I found myself in a crisis where my honored lived experience from this medicine and treatment was not honored. It wasn't long before I decompensated in a psychotic episode to the point where I took a fully automatic AR-15 assault rifle with 3 90-round magazines, over 300 rounds of ammunition, and I was in a standoff with several special operations teams after I robbed a bank. I was taken into custody through a negotiated surrender through FBI and other special ops tactics units. And the sad thing about this would have never happened if I'd had my lived experience honored, if I had been given the medicine that had proven very effective for breakthrough episodes. I was sent to the Federal Bureau of Prisons for 10 years, spent time in 6 penitentiaries, one of which was a forensic hospital. Federal Medical Center of Rochester, Minnesota, I was sent. There, unfortunately, as a case study, I was experiments were performed on me under sleep deprivation, light deprivation, noise and light induction and softening. Horrible things that I can't even begin to that you can't even begin to imagine. So this could be recorded what kind of stimulus would have what effect on me. In the cell next to me in a secured wing was Sheikh Abdul Rahman, the mastermind of the 93 World Trade Center bombing. He was given a studio apartment with 2 converted cells, a meditation fountain, music, mangoes, any kind of food he wanted. Tours from Washington would come and observe. I couldn't get a roll of toilet paper. I was left naked. Minnesota's cold in the wintertime. This is how mentally ill people usually get treated in these institutions, and in forensics, and in many places. But what I'm respectfully asking is that I have a beautiful life today. I'm back on that medicine I asked for in 1998. I've returned to college. I have a 4.0 grad point average in the honors program. And I have love in my life. I have people that love me and care about me. And my fear is that if I were to ever become ill again, decompensate, and the lived experience of my recovery was not honored and respected, and I was not given that treatment that I've clearly put down in a directive that works for me, I would become ill again. And I'm afraid that if I become ill again, I don't have another recovery in me because I can't do that again. So I humbly ask that you all take this into serious consideration of the many lives that are improved through quality treatment, and people do recover. So please pass House Bill 205 as written. Thank you.
Are there questions for Mr. Pace? I certainly appreciate you coming and testifying before the committee. It can't be the easiest thing, although after surviving the ordeal which you just described, it may be very simple to come and talk before us. So I really appreciate the fact that you were willing to do that. I do have one question. in the very beginning, before you had the original episode when you were beginning to decompensate, who refused you to give the medicine that was working for you?
I don't know if I should really reveal the physician's name or the providing facility.
It was just in a facility, or?
No, it was the psychiatrist.
Okay, in a private situation. It's okay.
I'm walking a tightrope
That's
with
fine.
certain things.
Don't
Okay.
step over the line there like that. Was any
Yeah.
reason given that they thought that another medicine was better, or?
Honestly, what I was told was that he just felt there was something more effective, and said that his judgment really needed to be that he just told me what he was going to give me.
Okay.
And said, I know what's best.
Okay. Thank you very much once again for taking the time to come and being willing to come and talk to us. Lynn Thorgerson? But you can pronounce that correctly. I'm sure I'm butchering it.
I'm Lynn Thogerson, and I'm here representing the Georgia Mental Health Consumer Network, which is a Georgia nonprofit that represents over 4,000 people living in Georgia with mental illness. And we've been working with other groups on psychiatric advance directive legislation for the past 5 years. It came out of a contract that we had with the Department of Developmental Disabilities, Behavioral Health and Developmental Disabilities, and where we would go around the state and we would work with consumers of mental illness, helping them fill out what was called a crisis plan, which is very similar to a psychiatric advance directive without the benefit of law behind it. And it's a very educational experience for people. They get to, and if you look at the form that's included with this bill, you'll see that it gives people the opportunity to stop and think while they're well what works for them. What medications work for them, what medications that they're allergic to, what type of treatment, what facilities that they've been to that have been good facilities for them. And it also helps them identify signs and symptoms of when they're not doing well. And they work with, these documents are signed by witnesses and then are also given to 5 supporters, so that other people can be aware of when someone's not doing well and try to take really quick interventive action to help them get back into the road to recovery. It's really very simple to other medical situations. I know what antibiotics I'm allergic to. I know what mental health medications work. And as a person working in the health field, I know if a patient came in and had something written down to give to a provider, it would, in most cases, be very, very helpful. So anyway, long story short, the Georgia Mental Health Consumer Network totally supports the bill as written and hope that you will pass it as it is. Thank you.
Okay, questions for Ms. Thorgerson? Representative Watson. Wait,
Hey,
you have a question.
thank you for being here. Appreciate your testimony and the gentleman's also. Can you go through the details a little bit of the crisis form that you're talking about?
There's a sample one that's included with the bill in the back. What it does is it's filled out at a time when someone is well, and it says, I'm just looking like on page 15, it says the following symptoms or behavior I typically exhibit when escalating toward a mental health crisis, and they would list them there. And so that's just an example of one type of information that they identify and then give to other people so that they can say, oh, if I'm not sleeping, for example, if you notice, then...
And the origins of this?
There's it's called the Wellness Action Recovery Plan. It's a plan that was developed by Mary Ellen Copeland, and it's used all over the country to help people living with mental illness stay in recovery. So by identifying how it is when I'm well, then I can start to see when I'm not feeling well and take interventive action really early.
Thank you.
Other questions? Okay, thank you very much. Okay, Susan Baldwin.
Thank you, Madam Chairwoman, and the members of the committee. I appreciate the opportunity to speak to you today. I am an attorney in Peachtree City. My name is Susan Baldwin, and I have been involved in this year's effort to get a psychiatric advance directive law for the state of Georgia. I have several seriously mentally ill family members, and I developed a special interest in these kinds of laws while I was in law school, so I've done quite a bit of research on the subject. I've worked very closely with our PAD work group this year, all of the stakeholders, and I respectfully request that you pass this bill as written. Our mental health system has a long history of entrenched paternalism. The reality is that consumers' treatment requests have always been, and still often are, ignored. The drive to develop PAD laws arose out of a desire to shift policy away from this paternalism and more towards empowerment and recovery. Having control over treatment is a very important part of the recovery process. I've worked closely with the consumer and advocacy groups in developing a law to support mental health recovery and control. On behalf of the consumer groups who have worked hard to reach a compromise on the current language of this bill, we ask that the committee pass the bill as directed. Thank you.
Ms. Baldwin? Okay, Representative Reinders.
Thank you, Madam Chair. Did you say you're an attorney?
Yes, I am.
And you have members of your family that would benefit from this bill?
Actually, I don't have any mentally ill family members here in the state of Georgia. All of my family members who could actually benefit from PAD laws are in other states, mainly Tennessee, where there is a PAD law, by the way.
Thank you so much. What kind of law do you practice?
Personal injury.
Do you have the bill?
I do at my seat. I do. Would you like for me to? Thank you very much.
The last gentleman, Camden Pace, was talking about how a physician was doing something, and I think his quote was, he felt something was more effective. I think that was your quote.
It was.
Okay, so I'm trying to get you to put on the advocate hat and the attorney hat, which is the patient safer if the physician may make a mental care decision different from or contrary to such declarant's instructions in an advance director if the mental health care provider or facility requested instruction has proven to be ineffective. And that would be what your guy did, right?
In this instance, I had simply requested what worked for me, as did my mother and father, and said he's doing just fine when he has his medicine, and it was the doctor's
Who did something that you felt was quote-unquote more effective. That's what he said to you.
in his opinion, in his judgment, he thought something else was more, but what had been proven was what we had requested for.
Right, but he said he could do what he wanted because it was more effective for you. Yes, and thank you. And so 5A, as an attorney, 5A for the members of the committee on line 123, I'm trying to get, and Mr. Lindsay's an attorney, and I'm trying to see the obvious contradiction here, which is someone made me do something because, quote unquote, he felt it was more effective for me. And how do we balance the needs of the patient if someone else just can override it because they simply find it could be more effective? And as an attorney, how do you balance that?
Well, I would point out that this bill only becomes effective, or this PAD is only triggered when somebody loses the capacity to engage in their own mental health decision-making process. But they can't be involuntarily medicated until they're a danger to themselves or others. So this is a voluntary request for early treatment that the consumer controls. And if the consumer has requested a treatment that is unavailable
See, I don't read it that way, Ed, do you?
Okay.
I mean, and you may when we get into it and she wants to hold, but see, the way I read it is that a mental health care decision different. See, I could say that I put it in, but if you feel in your opinion,
that's
which is
the
what he
agent.
did, which is what his physician did, felt in an opinion, then they can actually come up with a contrary or different than what he wanted, because in his opinion it'd be more effective. That's how I read what I've heard so far.
Yes, sir. The section that you're referring to is the empowerment of the mental health agent that the declarant has chosen to make decisions on his or her behalf.
Okay. Just
So-
something, as we move forward, I'm trying to find that balance of, I don't want somebody to arbitrarily, if I'm giving you my directive, but we're also sitting there going, but you don't have to follow it.
But you've carefully chosen your agent and had that dialogue
Right.
beforehand.
So, and you were, only because you said I'm an attorney and because if you're a good attorney, you could argue either side of it.
And I could, but
Right.
I
Thank you for
can't in
that.
good conscience
Okay.
argue the other side of that.
Thank you.
Are there any other questions? Okay, go ahead, Representative Gardner.
I think the intent is to show the advance directive and tell the provider, please use this unless certain conditions exist. I'm dangerous to self or others, which is the current law. We're not changing that.
Or if I find it contrary, or in my opinion, it could be a better, right? In my opinion, if I think it could be a little bit better to help you a little bit more, then despite what you told me, I do have the leeway of being able to do this.
It was important in working through the
I
bill with
understand.
all of the compromises to make sure that there was leeway
Okay.
for good professional standards.
Representative Lindsay.
This is a point of contention that I believe needs to be aired out. In the bill, the standard is higher than simply, I've got a better idea. The bill simply gives the doctor greater leeway only if the proposed treatment plan is ineffective. In other words, I don't believe that the doctor has that kind of discretion underneath the bill. If the doctor simply believes, well, you got one effective way, but I got a better way.
And if I may, and I always loved Representative Lindsay's intellectual capacity, but if you were representing the attorney for that gentleman that was just there behind you, you would bring into evidence that that physician made that decision on behalf of Mr. Pace based on what he thought was reasonable medical standards. That's what you would argue if you were Mr. Pace's physician.
We're trying very hard not to have this go into litigation.
Right, I know. And I'm trying to help you too. That's exactly what I don't want to happen.
Yeah, because the goal here is to advance knowledge for the doctor, to provide the doctor with clear understanding as to the patient's past, so that the doctor can assist it better. We're trying to avoid just those situations.
Right. Thank you.
Okay, Representative Pack, we'll take one more. Is it for Representative Lindsay or Representative Gardner? Okay, go ahead.
Quick question. It was my understanding that you could already have these type of instructions under existing law. Am I wrong about that?
Yeah, we don't have an express law. We have a patient advance directive in different circumstances, but not one dealing specifically with mental health.
Okay. May I follow up, Madam
Yes.
Chair?
Mm-hmm.
My question is relating to two sections here. One, particularly with line 253. I think this is the section where we're talking about when the facility has to comply with the advance directive. Am I right? It's, line 253 says, if a provider or facility is unwilling or unable any time for a reason stated in paragraph 1 of subsection A. So as I read that, the only way to refuse to provide the instructions is under subsection lines 236 all the way to 249. Am I correct?
That's essentially it, yeah.
Okay. Now, what happens if they're unwilling to provide the care that the person or treatment that they want on reasons other than it's the opinion of the provider that's inconsistent with reasonable medical standards? For example, if they have a religious objection.
They do have the discretion to refer the patient to someone else.
Okay. Would that be considered good faith or bad faith?
Referring to another one? No, consider that good faith.
A religious objection, would that be a, because that's not articulated in the only grounds is
Yeah.
articulated in line 236 to 249. Religious objection is not one of those grounds.
That's correct, it's not in there.
So by definition, would it not be good faith, so you don't get the immunity, or am I reading that completely wrong?
Well, I hadn't really thought about a religious objection, to be honest with you. That really hadn't, in all of our discussions, hadn't really come up. And perhaps you could help me with what kind of religious objection.
Well, I don't know what type of treatment that people will want. I mean, I could imagine if we're giving them all the discretion,
Yeah.
and we're curtailing the medical judgment of the doctor.
Yeah.
I mean, you can foresee some things that, and assuming that these type of documents have to be executed when they're of sound mind and body.
Yeah.
By nature, some of these individuals' judgment would be questioned when they execute a document. Am I wrong about that? So I'm kind of, I don't know an example I could think of right now that would fall under it, but I'm a little concerned about the medical provider's discretion in declining to provide the type of help, other than what's articulated in 250 and 259.
Well, I think what you need to be focusing on is, number one, is I think you need to be focusing on what the patient, in terms of informed consent, and what they're willing to consent to. Something that we would want to maintain control over if it was us, and something certainly we'd want to maintain control over if it was one of our children. So that, I think that needs to be sort of the focus here, is what right does the patient have in terms of their own body.
If you think about somebody with emphysema, for example, who continues to smoke over the recommendations of the doctor, I mean, that is the patient's choice.
Okay. One other question. Line 293. I understand that. I'm perfectly okay with 288 to 291 related to immunities. So you can't be subject to any kind of penalties or detrimental action if you follow the advance directive. 292 to 297, however, says it gives you immunity if you fail to. It has a limiting word here. It says solely for failure to comply. What does that mean? When you treat somebody, wouldn't there be other factors other than declining to provide advance directive? What I'm saying is I'm not quite sure if this gives you the protection that you're. I think your intention is to provide a broad immunity too.
Well, I'm not so sure how broad we are looking to provide.
Okay.
In the answer, okay. We have one more person here, and then we'll go back to questions of the author, and Rebecca Delhart.
Thank you, Madam Chair. I'll be very brief. I'm Rebecca DeHart. I'm here on behalf of the Georgia Psychological Association. We've been pleased to work with the working group of the different mental health professionals and the consumers on this bill. We thank the authors very much, and we're in full support.
Okay.
Thank you.
Thank you. Okay, now back to questions of the author to the committee. Ready for questions? Just wait a minute, wait. Okay. Okay. Representative Watson.
Thank you for bringing this, Representative Gardner and Lindsay. My take on this is a little bit sort of the opposite of Representative Pack. Primary care physicians generally are a focal point relating to health care of the mentally ill. If they certainly work in conjunction with psychiatrists or psychologists, and the estimates are anywhere from 25 to 40% of all primary care physicians' practices are mental health related. So it gives me a significant concern when I hear and I read the documents in the back here relating to side effects or potential problems related to a particular medicine and or allergies. I see, several new patients a week, and almost all of them come in with a list of their past history, their surgical history, their medicines, and family history, and things like that. And some of them are even laminated and handed to me, and they keep with them in their wallet and so forth. And I have obviously psychiatric patients, and I really have a problem with calling them consumers. I think that's very disrespectful in my opinion. But patients will come in from a psychiatric standpoint, and I will tell you I've had reams of pages from psychiatric patients. And whether it's an antibiotic or whether it's a psychiatric medicine, I think that we all should respect what the patient says, and I think that's obviously very important. But at times when a patient gives a description of, for example, a common psychiatric medicine that's been used for decades, like Haldol, and the patient gets torticollis, which can be a very scary side effect, though rather benign and easily treatable, and would never want to take that medicine again. And yet, 10 years ago, we used it at high doses, or 15, 20 years ago, and now we use it at just a sprinkle amount at bedtime. So to tie my hands to say that that person would never want to take a particular medicine, or maybe even a class of medicine, makes it real difficult for me to feel comfortable with this. That's a very difficult issue for me as a practicing physician, and then as a state representative. And then the untoward things that we see all the time with from the FDA. The way they approve medicines and new indications for medicines that the FDA does, that's happening all the time. I mean, just this week or last week was a breast cancer medicine that was just approved. And we use many medicines and combinations of medicines, especially in mental health. We use combinations, or almost like chemotherapy. Some work for others and some don't work for others. I guess I'm getting to the point that when we're looking at the last few pages there, which I think are good recommendations, I'm not so sure they need to be in law, though. And it says, I cannot tolerate the following medicines because of, and that's 501, line 501, and then I'm allergic to the following medications, 505. And certainly, I just see where that's certainly is good, and I think it should be laid out there, just as it is with my patients who may be allergic to penicillin, or maybe who have side effects related to codeine. I mean, how often do I see that it's listed that codeine is an allergy, yet it's generally the side effect of nausea, vomiting, or abdominal distension. That's a very common side effect, and yet is almost always listed as a allergy. So what that does in many times, if the patient may or may not be alert or cognizant of what's going on, whether it's from psychiatric illnesses or whether it's because of medical illnesses, it makes it very difficult to prescribe a medicine or derivative thereof for those particular medicines. So that concerns me a lot, and putting this in statute concerns me even more to make it law. I think the communication should be lauded. I think that is a wonderful thing. The communication aspect of this is good, and I think that not only should mentally challenged patients or psychiatric patients or consumers should certainly have this, but I think that most of us would want to do this when we go in to see a physician. I don't know whether that was a question or whether that was a commentary. I'm sorry.
Well, what this this isn't necessarily the law. This is the form that's to be filled out in terms of providing the doctor with information as to what has and has not worked in the past. And I do understand, perhaps, you and I talked about perhaps your concerns are more centered around where they basically refuse certain treatments, not so much discussion of their past symptoms or their past.
Well, I mean, if you look at line 81 on page 3, 6 says medications that a declarant is taking has taken in the past and the effects of such medicines. I mean, that's where that's coming from, I presume.
Yes. And I would assume that these, what's that is there in order to be able to inform the doctor as to what type of past medications that they've taken. As you well know better than me, because you actually treat these patients, is that oftentimes without a pad, without something like this in place, you're not going to know what the person's past medications are in terms of what has not worked.
You know, certainly when you're treating patients in the emergency room, as through most admissions to hospitals, they come through the emergency room. Many times you don't know, and but if you have interested family members and you take that history as we all do and should do, then hopefully that comes to light. I mean, we deal with the unknowns all the time. Unfortunately, we deal with it a lot more than we would like to. And to have a past history that's well outlined is good. You know, putting it into law is another thing.
Okay.
Well, if I can sort of try to break it down, I mean, you're concerned whether or not the patient is required to outline what their past is, or your concern is in terms of the patient declaring what they will and will not agree to in the future.
No, go ahead, Dr. Watson. I was waiting for your response to it.
So the patient lists the ones he has had problems with, he or she has had problems with and or allergic to, in quotation marks, and then the physician is, you're telling me that the physician, you know, can or cannot give that particular medicine. My concern with is the medicine like Haldol, which had a side effect, which can be certainly given again at a lower dosage without any problem, and yet that's the issue that I have with it.
Well, and that's what I'm trying to drill down. I'm trying to drill down. It's not so much you're concerned about the listing of past.
Uh-huh.
You're worried about how it may restrict your ability to provide a certain medicine at a different dosage level than the patient has had in the past, or in a different manner.
Right, exactly.
Okay.
Okay. Okay. You're finished, Representative Watson? Okay, thank you. Representative Kaiser.
Thank you, Madam Chairman. I just wanted to ask if it's okay with you if Mr. Pace could maybe speak to this, and I know the author certainly knows the intent of the bill better than anyone, but when you, I guess what I'd like for you to comment on, I have a mentally ill family member who's deceased, and the number of medications and treatments that were prescribed to her, I think in her good judgment would have said, no, this particular thing worked for me. So I guess to me that's sort of the meat of what we're trying to do, and certainly putting in law that doctors should follow a directive like this is important. But would you just speak to whether or not, had you had this directive when you were asking for a particular medication that you knew, knowing your own mental illness, history of mental illness, do you think this directive would have made a difference in having gotten what you needed prescribed at the time?
Absolutely, without doubt. For me, as it pertains to me, the spirit of this bill really is to take my directive, which has been witnessed by 2 other people as tried and true and effective for when I'm in a state where I'm not capable of participating in my program, that during a well state of mind I wrote this and witnessed, that the lived experience of what actually works for me and what can get me back in recovery is honored and respected because it is proven and true. And just to step a bit further, my whole family's medical. My mother was a psychiatric nurse at Mayview State Hospital in Pennsylvania in 1962 and 63, back in the dark ages of mental health. Her father was a surgeon. My brother's been in open heart recovery for 15 years. We've had this conversation many times. And what we have all come together as they're my support network. What they would like to see is that when something works, when something makes me well and gets me back, is that it be honored. And the provision in this bill already allows for the physician to deviate from the PAD if a state of contraindication is ruled, which that's their job. Nobody's trying to take that away. We love doctors. We want them to do what they were trained to do. But in the situation of arbitrarily tossing my desires and wishes away that have worked for me, that's what I'm opposed to, is just, oh, well, I just think I need to do this. And honestly, I'm just going to say, it might have been some pretty pharmaceutical rep that just came in that day. Yeah, okay, so, there it is. But, yeah, if I'm doing well and I find myself in a crisis, and obviously I'm not in my right state of mind, I'm in an emergency receiving facility, but my PAD is enacted, and they're like, okay, well, this particular medicine, this dose, whatever, it's been signed off on. Hey, this is great. We're going to get him discharged in 72 hours. He'll be back home, and it'll be wonderful. That's the whole spirit of this for me, and it allows immunity for the physicians to, if they feel like they need to, with generally accepted medical practice, to deviate because of contraindication. There's no liability on their part. It's in there. So if that addresses that.
It does. Thank you.
Thank you very much. Representative Broderick.
Thank you, Madam Chair. Just a sort of a logistics question. Certainly, in any situation where the patient, whether it's a medical facility or whatever, the more information that's available is certainly very useful. But I'm thinking about, suppose the agent shows up at the pharmacy and says, I want prescription records back to X date, yada, 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 as far back to determine, and this is for a medical history to determine adherence of the patient in the past. Should there not be some sort of authentication, here it says this form does not need to be notarized, some sort of authentication that, I know you've given the HIPAA waiver on it, but some sort of authentication that, yes, this is a valid document.
Could you give me a line?
This is 775. It says this form does not need to be notarized. Would it not be beneficial to at least have it notarized, which is a pretty simple thing to do, just from a logistics standpoint, to so that whoever is receiving the request has some form of authentication? Page 24.
Yeah, I understand. I mean,
it doesn't mean I know that means that it could be notarized. That would not be a problem.
There's no prohibition from it being notarized
Exactly.
or signed by your physician or your treating mental health provider. I mean, in the best of all
I just know my
possible-
company's policy would not recognize this document without some without some form of authentication.
Okay. Thank you. Representative Barr. Okay, thank you. Representative Reinders.
Thank you, Madam Chair. Just some logistical questions. How many other states do this?
27.
27. Did you get this language from any of those states?
we started with it, yes.
Which states are those?
North Carolina.
Yeah, heavily adopted North Carolina, and then we worked within a study group for tweaking for.
Okay, thank you.
A lot of the language came from the current medical advance directive. We wanted to make sure that we were not putting anything about the agent that would be in conflict with the medical advance directive, even though it's in a separate section of the law.
I wanted to go off of Representative Pack's question in regards, because this is actually, I've seen this firsthand. Do you consider someone intentionally starving themselves to be a good faith?
I'm not sure where we're going here.
It's a simple question.
Right.
If you were in a facility, based on your definition of facility, which could include home, according to your definition, if I'm
It's very broad. Same as the medical
I've seen
advance
this,
directive.
and I intentionally, because of, for whatever reason, the reason really doesn't matter, because it's my it's my health. But if I choose, because I want to save my family the pain and the suffering of cancer, or a host of other reasons, cost, if I choose to intentionally not eat, is the facility or the home obligated to then feed me?
That's a question that I'm not sure I can answer, to be honest with you.
It's the patient's choice.
It's the patient's choice. So now all of the people that are sitting there working at that facility, if we go down that route, are sitting there going, I can't not feed somebody. It may not be a religion. I just can't sit there and watch somebody starve to death. Just can't do it. Unfortunately, sometimes they're sent to the hospital, which according to some of these rules may not be able to happen if they write it correctly. And they would be, what's it called? Stomach fed through a stomach tube?
Feeding tube.
Feeding tube?
Yeah.
Just things to think up in the broadness of the bill. Additionally, on this here, listen, you can't get it all out of me.
Southern.
Yeah, thank you.
You're welcome.
I'll tell you what, baby. On some of this here, let's just, if I say that it's my intention to stay at home or in the community, does that mean that I have to stay at home or in the community?
That simply means that you don't have to be institutionalized.
We'd rather not be in the community.
Rather, but if you're my advanced, I'd rather not, but you could actually say, no, you're going anyway.
Who could?
But whoever
Your agent?
I mean, my desire is I want to stay here. You could just take that upon yourself. And there's some other examples like that, and I'm just trying to,
If they're dangerous for others, then they can be.
I generally react to being hospitalized as followed. Now, this is in Bill.
I understand. I mean, that's the form that's being recommended, yes.
Can my what is it called, my advocate, can they fill this out for me and just get me to sign it? Now, that's a legal question, Ed.
Yes,
Representative Lindsay, I'm sorry.
that's fine.
So my wife could fill mine out like my W-2 and just say, sign here, and this is how much we're getting back, or whatever. You could fill out your wife's one of these, correct? And she could sign it. Would that be legal?
No, the person has to sign it and it has to be witnessed.
Okay. Later, going to Dr. Watson's point, the condition of the person changes. How do you amend this then? What would be the legal way to amend this?
It can be amended at any time the person's in and not in a crisis situation.
And if that amendment happened after the person had become mentally not capable of making their own decision,
They can't amend it.
then they can't amend
You
it.
cannot amend it when you're in a crisis.
Though they may need to be able to do something than what they actually requested, they can't amend it because their mentally is not there. I see it kind of as a cycle.
Well,
I
I'm
can't
not sure
fix what I need because I'm not mentally capable of fixing it.
But the doctor has certain discretion to override the directive, as does the agent in certain situations. I think we've outlined those earlier.
Okay, thank you. That's all for now, Madam Chair. Thank you.
Representative Pack?
Thank you, Madam Chair. Two questions. I have confusion about some language in here. Line 276 to 278, it appears to say that a provider or facility that provides mental health care could turn away a declarant, which would be the person with the advance directive, if they're unable or refuse to ensure payment.
Yes.
Is that one of the grounds that they could, under A1, to say, we're not going to treat you?
Yes.
The second question I had was 321 to 325, the law enforcement officer. I looked at the suggested form, and I'm trying to imagine a situation. There's a crisis situation, and the law enforcement officers generally are one of the first responders. Am I usually correct about that?
Can you answer his question? Actually, we have somebody with expertise in working with law enforcement on advanced directives. Would you like to?
Sure. Let me pose the question then.
Okay.
And in the form, I only see one instruction related to law enforcement, which says, I respond like this to law enforcement. Then I look at language in 321 to 325, which doesn't seem to kind of provide any instruction for the law enforcement officer other than this is how I react, which is generally probably negative to law enforcement. And the concern that I have is restricting, by defining, defining a law enforcement, giving them good faith reliance immunity, and having them consider valid psychiatric advance. I'm wondering if that is trying that would confuse the issue more, because my understanding is a law enforcement officer has immunity, period, when it comes to dealing with a crisis situation with public safety. So does it mean that if they, same thing in the doctor's context, if the law enforcement agent takes actions that seem to be contrary to what the advance directive says, does that mean that that law enforcement officer does not have immunity under this bill?
If the chairman would allow Nora Haynes, who actually works down in Savannah with law enforcement, to describe a little bit about how it actually works, it might be helpful, because that's part of the reason it's in here.
That'll be fine. Nora, you want to come to the podium? Do you want somebody else to come and speak to it also? If you just identify yourself when you...
I'm sorry.
Going to tag team us on, Nora.
I'm Nora Haynes. I'm with NAMI Savannah, the National Alliance on Mental Illness. And NAMI, Georgia, we train law enforcement. We've trained about 5,000 law enforcement officers in the state. To answer your question, from my perspective, if a law enforcement encountered someone in a crisis, first of all, they wouldn't know they had a pad. Right? So I would think that all the rules and regulations with immunity for law enforcement would apply. So I don't see whether they had a pad or not would have would make any difference what the law enforcement officer did, because obviously he wouldn't know they had a psychiatric advance directive. Is that?
What happens when they do have a pad? You created something.
Well, the law enforcement officer, when they encounter somebody in crisis, I doubt they would understand when the person said, I have a pad. The officer's still going to do what they have to do to keep the person safe. Right?
Right.
I don't think so.
So they would still have immunity, even if the pad said, I don't want an officer to take me to jail or
Right.
whatever.
So my point is then, if that is the case, and that's my understanding, lines 321 to 325, by articulating a standard in which they receive immunity, would seem to narrow that immunity. Is it even needed?
I don't see it that way, but I respectfully understand what you're saying.
Suggesting we don't need that.
Right. I think they have immunity, whether or not they act in good faith. We presume that the officer always acts in good faith in that situation.
Right. Especially when they have CIT training.
Thank you.
If I could just say, at one point, we did have a registry that would be online. And the long-range goal, of course, is to figure out a way to get these pads available online to somebody who needs them, when the person is in crisis. And I suspect that came when we were thinking about a registry, which we just don't have the money to do. So, but that language is not essential.
Representative Pack, does that answer your question? Representative Watson. Thank you, ladies.
Just if y'all wouldn't mind answering, so an officer gets called to someone's house, and many times the officer, I presume, is going to make a judgment of whether or not that person's at harm to himself, and I find it a little bit hard to believe that somebody who is a little savvy, hopefully has or their family members would present the pad. I mean, I can't imagine that not happening. Actually, I can imagine it not happening, but I can certainly imagine it happening also. Does that confuse the issue more? Does that help it out, having the pad there for the...
I just want to add that, unfortunately, in the state of Georgia, when a law enforcement officer goes into someone's home and they have not committed a crime, the law enforcement officer can't interfere anyway, because Georgia is one of the few states that you have to be a danger to yourself and others, and you have to have committed a penal offense before the officer can take you involuntarily.
I think I'm Pat Strode. I'm the CIT Program Administrator for NAMI, Georgia. The way this is written, to back up what Nora just said, this would give the law enforcement officer the ability to adhere to this psychiatric advance directive. If there is not one, let's say I'm in crisis. I've not committed a crime. My family knows I have a psychiatric advance directive, but I haven't committed a crime. But if my family presents my directive to the law enforcement officer, that would empower them to adhere to that, to take me wherever it is I needed to go, whatever emergency room I preferred or whatever. If I have not committed a crime, the officer may not say, okay, let's take her to the hospital. Because I have not committed a crime, that officer, under our law, the way it is written now, can walk away and not provide me with any assistance whatsoever.
So that can go both ways. So you're called for disturbing the peace. You're out in the front yard, naked or not naked.
That's an offense.
Well, you know, I'm out in the yard with my clothes on, and I was yelling earlier, and the law enforcement officer's making a judgment, and you hand him something, and I would presume, as Representative Pack pointed out, that you would fill out the forms that when law enforcement comes, I have a negative response, and I don't want to go to the hospital, and I don't want to go to the emergency room, and that's what's in my advance directive. Is that good patient care?
No, the officer, I would think the officer could make the judgment at that point.
To take them to the doctor instead of to the hospital. You could have some options.
What do they do if it's after hours? And the option is the hospital or the jail or...
Then you take them to the hospital.
Unavailable. There's a bit of provision in there for unavailable.
Mm-hmm.
Okay, we're going to do that one. So it covers it.
We would still want the officer to act in good faith, to get the person the help that they needed. And the PAD allows them to do that.
Representative Henson. Where is she?
Oh, no. I don't know. Go first.
Oh,
I didn't.
okay. I just have one question for clarification, and I've moved it. On the medications, on line 514 through 525, it's where you talk about, in the event I need to have medications administered, I would prefer and consent to the following methods. When it says I consent to it, there are psychiatric conditions where when a person's in crisis, like if they didn't want to have anything IM, but the IM medication is the only way. I mean, you can't get them to take liquids or pills. And for a while, and this is especially true in paranoid schizophrenia, when they don't want to take anything, and you would have to give them IM injections for a while. The fact that it says consent, would the outs that we have in here cover?
I believe it would.
I think that would cover and release the physician. Okay, only because sometimes that's not easy to do, to administer an IM medication when somebody doesn't want it, and that's why I wondered if that would cover it.
Yes.
Okay, further questions from the committee? Dr. Watson? Okay.
Madam Chairman, if I may, we've gotten a lot of good input from the committee, and I think it would be prudent for us to sort of consult further with the legislators who've raised some very valid issues and see if we can tweak the bill further before we move on.
Okay. Representative Lindsay is the author of the bill. That's certainly your prerogative to do that. I think the committee did raise some good questions and may have some concerns. So it's your request that we not have a vote on the bill today and that we continue the discussions.
Allow me to continue the discussions, allow us to continue the discussion with the various members can roll out a bill that everyone can be comfortable with.
That's fine, so allowed. Thank you very much for coming and presenting your bill.
Thank you.
Bruce, come here a minute. And thank you to the advocates, and Mr. Pace, thank you very much for coming.
Thank you for having me.
Yes, you have time to do it. Okay.
I'm looking for my magnet. I'll find it. I get it.
Okay. Thank you for checking, because I thought he was in communication with you or something.
Okay, doesn't matter.
Okay. This happens a lot when we get to this point. Okay, you going? Okay. Attention, let's move on to Representative Williamson's bill, House Bill 332. And Representative Williamson, I understand you have people that want to speak on the bill. Have they signed up to speak? We've got one person. Is there somebody else that needs to sign up to speak? I need to ask you a question. Not about this. Not about this. Which one are we working on?
332, substitute. Did he give you the original?
Oh, no, I didn't have a copy.
Folder, and then he just-
Okay, to the committee, they're passing out a substitute to the bill. This better not have major changes in it, Everson Williamson. The last minute, I don't like major changes. No. I do not want to hear an education bill. Thank you very much.
Thank you, Madam Chair, members of the committee. Today I bring before you for your consideration substitute the House Bill 332 LC 212165S.
Everybody got the right substitute? We're working on the substitute. 212165S. Okay, go ahead.
Well, first of all, thanks for the hard work y'all do. I've been at the back of the room, and I have a deep appreciation for those of you that serve the medical needs of our state. Don't pretend to have any deep medical knowledge, but I do know a little bit about business. And this bill comes at the request of the board that regulates registered nurses and licensed practical nurses. They both happen to have share the same executive director. Both boards are unanimously requesting, and I did confirm that with both board chairmen, to combine into one Georgia nursing board. This board is a good. This move would be good public policy, I believe, because it will reduce the total number of board members from 15 down to 13. It actually eliminates one extra board meeting per month that currently the Secretary of State's office is having to administer and make sure reports are ready for and copies and everything else, and it allows for more efficient administration of the board for those things that they review. The substitute, it was realized after I first dropped the bill that we really needed to change a date to make sure that we had a phase-in time. We wouldn't want an entire board to change over all at one time, so there's an opportunity for the board to phase in over a 12-month period. And my Senate substitute needs one technical change to affect that. On line 16, it should have been July the 1st, 2014.
Need to make even to the current substitute.
Yes, ma'am.
Okay.
Then in the substitute relative back to my original bill 332 on line 38 where we're describing the constitution of the board, and there again this is language that both of the boards, both the LPNs and the RNs agreed to. We're adding in line 38 after the first two words home administration, we're adding or nursing service administration in the description of the board members.
couldn't that be a total, Representative Williamson, let me just ask you right now, okay, nursing homes, and are you trying to cover nursing homes there, or nursing service administration could be somebody that's an administrator in a regular hospital, couldn't it?
You just left the business world to the medical world, and I'm at a loss for that. But that's Tim Fleming with the Secretary of State's office here says that is correct. Your interpretation.
If I may, Madam Chair, thank you. This was a request of the boards that we met with several weeks ago. They came up with the composition of this board, and that was what it was left at for one of those two to be a member.
Okay, so you could actually get somebody, you could actually have a board that has no one from the nursing home industry on it, or you could get one that doesn't have an administrator, a nursing administrator from Piedmont.
Correct.
Correct. Either or.
Yes, ma'am.
Okay. Go ahead, Representative Williamson. Were those the only changes?
The other, I'm going to let Tim, Mr. Fleming, who's an attorney, address the construction of this. Explain how the General Powers Act was pulled back into the bill to make sure that it was.
Thank you, Representative. To set the record, I'm not an attorney, but working every day with this. What was added from the original bill was basically the general powers of the board, which is found under Section 2, starting at line 55. The general powers of the new board, basically what's in the code now, and then had to be removed was the general powers of the LPN board, since they're going to be combined to one board. And the general powers stayed the same as what they are now with the current board.
They were the same for both
yes,
boards?
Yes, ma'am. The same for both boards. It just had to be restated.
Okay. And those are the three changes.
So restating lines 55 basically through 108 with the addition of line 100, which says deny or withdraw approval from non-compliant practical nurse education program. So that would be added into the code. So that is the only additional change from the original bill that I dropped.
This one's the deny or withdrawal approval from non-compliant practical nurse education programs?
Yes, ma'am.
What?
Excuse me, Madam Chair.
Practical nurse education programs,
right.
Okay.
This was once again, this was language that the two boards got together, and it was one that they wanted to add, number 23.
Okay. All right. Do you have any? I know that's the Secretary of State's office. Don't do this ever again in my committee. Don't bring me a bill with these many changes at the last minute, right? So I like to vet them a little bit better before that. And, I mean, I know that they're new down there, but I know you also have a former member who knows the rules and how I like to do it. So we don't want to do that anymore. Okay, members,
yes,
questions from the committee? Representative Pack.
Thank you. Thank you, Madam Chair. Quick question. I know it looks like you're merging 3 boards into one. Am I correct? Two into one? And Section 2, 4326.5 gives the power of the board, and you redefine the board under Section 4 to include the Board of Nursing, and you eliminate the Board of Examiners of Licensed Practical Nurses?
Yes, sir.
Is there anything that you need to, since you're removing the power of the examiners of licensed practical nurses, where's the provision that bestows that power into the newly constituted board? You understand what I'm saying?
Yes, sir.
Okay. Thank you, Representative Pack. Go ahead.
Because here's my question. So Section 2 gives the general powers of Georgia Board of Nursing, okay? it doesn't have any changes to the power of that board except for line 100, which has deny or withdraw approval from non-compliant practical nurse education programs.
Representative Pack, I'm going to exercise the chairman's prerogative on this, and I'm going to hold off on this bill, and that will get, we're meeting again on Wednesday, and that will give them a chance to answer your question and make that correction if it needs to be. I would also like to see the old information from the old board and what powers they had, and to have somebody come and talk to me about this bill. So I know, Representative Williamson, you haven't done this before us, but this is a big change. I would also like to know, and somebody explain to me, how putting two boards together and not expanding, or when we've talked about how much we've cut the staff. And the nursing board, if I remember correctly, was already telling me that they get somewhere between 160 and 200 complaints about registered nurses every 2 months. Now they're going to be dealing, that same board is going to take on the responsibility of the complaints that come from the LPN board with less members. And one of the things they do is parcel out these complaints to different members on the board for them to go through ahead of the time and see if they rise to the level of where the whole board has to meet them. I don't see how this is going to make it safer for the patients of Georgia for us to, police what's happening, and with nurses especially that have problems either from, drug addiction, giving the wrong medicines, killing patients like we had one recently with the wrong medication. I don't understand how that works. To combine two boards that are already short, cut the staff on them, and they're going to take care of more things. Our former representative, Mr. Harper, would you like to come and explain to me how that's going to work?
Do that now, or I can come see you.
Go ahead, it's fine. Go ahead and tell us while we're here.
I think the main thing to remember is we will remain with the same number of Secretary of State staff for this one board, and the reduction in the time frame that amount of time it takes to prepare for additional meetings, because now they have to prepare for two, with getting the packets out, back and forth with questions from board members, staffing that board meeting, and then the follow-up with the minutes and making sure everything is squared away. So there is a substantial savings in time from the reduction of that one board. And that, quite frankly, was the impetus for this move from the ground level, where they're doing the blocking and tackling and asking for this change. I would also point out that we're one of the few states that have a separate LPN and RN board. So I understand your question, and I think there's merit there, but keep in mind we're only reducing by 2 members. So, and a lot of that preliminary work takes place at the staff level, which again can make use of a lot of time savings in those complaint cases and so forth that they're passing out. So, yes, ma'am.
Right, since the board is an uncompensated position.
Yes, ma'am.
Except, do you pay them a per diem or travel or anything to the appointed board members?
Yes, ma'am. They get the state statutory per diem, but they're not compensated in a salary for being board members.
So basically, we're cutting 2 members from a board that now is going to, and I know it's combining the two, but they're going to deal with just under 160,000 nurses in our state. We really see it as efficient to drop 2 people who would be reviewing the cases and the work of the board.
Well, I think I think the extra time that the staff has to make those determinations upon which ones rise to the level of being reviewed might compensate for some of the time that, and not every board member, as I understand it, engages in those reviews. Newer board members currently, and board members that may not have the necessary background based on the complaint. A lot of complaints are centered, I think, around 1 or 2 main areas, and there's often a disproportionate number of those passed on to certain members that do more of the heavy lifting than others. So it's not like it's evenly split as of today.
Okay.
Does that help?
Yes.
Yes, ma'am.
But I still have concerns. I mean, when we have to wait until you have money in a bill that passed over. We had to put it in there, that mandatory reporting for nurses that are addicted to drugs or addicted to alcohol or have other serious problems, that we can't have mandatory reporting start until we have the money to pay for it. I just have real concerns about how we're going to take care of what we already have, and my concern for the patients of Georgia. Representative Pack.
A quick question.
Yes, sir.
I generally support merging these boards. As a matter of fact, I think I was a proponent of Secretary of State's efforts to try to simplify these boards.
Yes, sir.
My simple question was, it seems like two boards had either identical powers or some separate or different powers.
Mm-hmm.
All I wanted to make sure was the newly created board has all the powers of both boards. And that's just my simple question.
Sure. I think it does, and,
Okay.
and I think the composition of the board is where the main, when we got word that the two boards wanted to merge, I asked for two pieces of information. Number one, a unanimous resolution from both boards requesting consolidation, which we have. Number two, an MOU on the major deal points so that there wouldn't be a lot of squawking once we got started, and both boards would have agreed to, again, to the major deal points, that such as composition of the board and some other things. Like Representative Williamson, I've spent a fair amount of time in the business world, and I thought with those two pieces of information, being again the blockers and tacklers and the people that are doing the work daily, would be adequate. And then again, having the composition of the board, which is where the real conflict can sometimes come in. And so it's my understanding that that is taken care of to the satisfaction of current board members and the executive director in Macon.
They certainly sing it. They're telling, I'm sure that you have that they want to combine the boards, but when you talk to the board members individually, we certainly get a different story about the workload and how much trouble they are having to deal with what they already have.
Certainly. I mean, the nursing board has done, along with lots of other boards, have done an incredible job of actually improving their service and their work, which means a lot higher workload for them.
Right.
So I wouldn't disagree with that for a minute, but we would hope, again, that the efficiencies gained by a substantial reduction in meetings would compensate, and we feel like, and they feel like, that, if you will, Madam Chair, that the juice is worth the squeeze on that, and that's why they requested it.
Like I say, Representative Reinders.
Thank you, Madam Chair. For members of the committee, I would not be surprised if we don't see something very, very soon in regards to all boards in Georgia. What's needed, go through the process. As you know, we've seen a lot of, just in this committee, what should a board do, how much should they pay, where should the funds go. The Secretary of State has come out with last year with an efficiency streamlining kind of, at least as they see it. The beauty is in the eye of the beholder. As Madam Chair said, is that going to be good or bad? And the answer is probably going to be yes to some and yes to others, and no to some and no to others. But I wouldn't be surprised if we don't. This just seems to be getting a little bit bigger all the time. And so I would just ask everybody to be a little cautious, because you maybe see something else come down the road.
Well, not that I practice any more nursing, but I really don't want some lawyer deciding whether I've done something right or wrong that has no knowledge of nursing and whether it's right or wrong. So I just hope that that is not the way the board is going. I'll put in my...
No, ma'am. I think,
like last year when we had the overall thing made up of a group of people that
I think this is quite frankly, and I'm not sure with Chairman Reiners, but I think this is a direct opposite action from what you've seen in legislatures prior. These are the people that are actually on the board asking to be consolidated to better do their work. I think this is.
I was just talking about what Representative Reiners were talking about.
Well, we have some that are saying, you know, I need to get this much more in fees. It needs to be that I need to have expanded. It needs to be that I can turn around and have as many hours as I want continuing education. We're just getting a lot of different issues. Y'all have heard them in regards to various boards. Just let me create my authority, then shut the gate as soon as I'm done. Right? We've all seen that, and I think the best example I've heard was from a legislator that said it's kind of like jury exemptions. Once you open that floodgate, then here everybody comes. I'm just saying that I think that I wouldn't be surprised if we don't see something come down the pike legislatively that gives us an opportunity to just exactly what does Georgia want to do? What does Georgia want to do as it relates to various boards?
Well, and I would like to state I'm not against the Secretary of State. I know y'all are working hard with budget restraints. I'm just concerned about the patients of Georgia when it comes to nursing and the medical field. I'm concerned about whether we're going to, you know, improve and have continuing education and police ourselves by the very bad apples, and by bad I mean incapacitated because of drugs or alcohol or so forth. I'm just concerned about how we go forth in making it a little safer for patients in our states. It has nothing to do with the Secretary of State's office. Representative Kidd, do you have something before we continue this discussion?
Yes, ma'am, if you don't mind. How many nurses are on the LPN board currently?
Currently, there are 7, I think.
And how many are on the professional nurses board?
I think there is 8 currently. That's right.
No, thank you.
Yes, sir.
Are you saying that we're going to go from, I think the question he was asking, I think, is how many RNs are on the LPN board now? RNs.
There's no RNs on the LPN board.
Okay. When we combine the boards, how many LPNs will be on this new board? Is that the question, Representative Kidd?
No, ma'am, but that's a good question.
Oh. Well, how many LPNs will be on the new board?
I think there can be 3 to 4, depending on the selection of which where the or comes in.
Okay.
A mandatory 3 up to 4.
Okay, thank you very much. I just would like Representative Williamson, I'll tell you what you need to give. We'll be on Wednesday, put you on first, and see if we like it.
Thank you.
Thank you. And please, if you come from the Secretary of State's office or anybody else, don't bring me things with big changes at the last minute.
Yes, ma'am.
Okay, that's when we make mistakes and when things get through that shouldn't get through, and I just have a problem with, you know, getting 2 or 3 more pages added on, even though it appears simple. I just want to make sure we don't make major mistakes.
Yes, ma'am.
Okay, Representative Kidd, are you ready? Pardon?
May I present from here?
Oh, no, I really want you to go down to the podium. You're fine.
Thank you. I bring to you the committee substitute, which is in your folder, to House Bill 192. The changes from the original bill, which said just cosmetic conditions. Some people say, well, what is the definition of cosmetic? And so we put in the definition of cosmetic that was satisfactory to both the Podiatry Association and the Medical Association. This does not in any way expand the scope of what a licensed podiatrist can do. It just says that they can do cosmetic conditions, and by doing that, they can, when they bill the patient, they can use the CPT codes for cosmetic, and that's about all it does.
Okay, we're working off LC 33510-8S.
Yes, ma'am.
Questions from the committee?
There's a lobbyist for the association here if you need to speak to him, but they'll be glad to answer any questions.
Okay. And what's the, Representative Kidd, what's the purpose? And if
the purpose, Madam Chairman, is that, from what I'm told from the Podiatry Association, is that while they're licensed to remove warts or a very bad birthmark or whatever it might be, and they remove it, that sometimes they get having a hard time being reimbursed because It might, the insurance companies, other people might be referring to that as a cosmetic condition, not quote unquote a medical condition. And by putting the word cosmetic in their licensure bill, then they can use the CPT codes for cosmetic, and they might get reimbursed for it.
So we're not mandating the insurance companies to pay for it.
That's correct.
Since they don't pay for cosmetic
That's
procedures in other areas of medicine. It's just that they feel like if it's in the code, they might
Yes, ma'am.
be
If
able to
it-
get
if
paid
it-
for it because they would have a code number.
If it was mandated and so forth, we wouldn't be in this committee, we'd be an insurance committee.
That's correct. Okay. Are there any questions from the committee? What's the committee's? Okay. We have a move to pass and second. Any discussion? No, hearing no discussion. Everyone in the favor of the passage of substitute to House Bill 192 LC 335-108S, say aye. Anyone opposed? No. Sounds like the ayes have it. Thank you very much. We are adjourned. And we will have a meeting on Wednesday. I think it's at 2 o'clock, and if we run late, we'll have it because we're getting close to 30th day, and there will be, I'm sure, a couple other bills.